All right, let's get right to it. For this explainer, I want you to step into the shoes of a senior medical examiner and an attending acute care psychiatrist. We are conducting a strict, zero-filler audit of the core execution traps that catch clinicians off guard literally every single day. Out on the wards, it's incredibly easy to play what I call the clinical lawyer, kind of getting distracted by circumstantial evidence, noisy labs, and textbook biases. Well, instead, we're going to apply uncompromised mathematical rigor to our diagnostic criteria. So, court is in session.
Okay, our docket for today is set. We're looking at the chronological axis, automated reflex physics, functional impairment thresholds, a mandatory validation drill, and finally, the executional pearl. Let's dive in.
Module 1. The chronological axis, psychotic spectrum timelines.
Picture this. A 23-year-old is brought in with classic new-onset auditory hallucinations and a distinctly flattened affect. The clinical lawyer looks at this and immediately wants to stamp schizophrenia right on the chart. They might even get distracted by incidental noise, like, say, a single positive urine drug screen for cannabinoids, arguing it's just drug-induced. But the judge? The judge ignores the noise and absolutely demands proof of duration. The primary underlying psychotic architecture can only really be revealed by time.
This strict chronological axis is exactly how we have to operate. It's the ultimate 50-50 dilemma. If the patient had a completely normal baseline exactly 5 months prior to presentation, schizophrenia is completely off the table. Symptoms lasting at least 1 month, but strictly less than 6 months, definitively dictate a diagnosis of schizophreniform disorder. Schizophrenia requires a full continuous 6-month disturbance, and yeah, that includes prodromal or residual phases. You have to hit that structural wall.
This singular variable, that 6-month duration, is the heavy gavel of diagnostic math that corrects your clinical course. You absolutely cannot negotiate with this number. If it's under 6 months, you hold back the schizophrenia diagnosis, period.
Moving right along to Module 2, Automated Reflex Physics, Neuromuscular Toxicity.
Take a look at this classic board presentation. A 73-year-old woman treated with risperidone is brought in confused, with a temp of 39.4 degrees Celsius, rigid extremities, and a massive creatinine kinase spike of 2,000. Getting this wrong isn't just a charting error, it is a fatal management mistake. The trap here is misidentifying the underlying receptor pathology when confronted with a high-potency antipsychotic toxidrome.
Now, what's truly fascinating here is the reflex divide. Both conditions give you fever and altered mental status. But neuroleptic malignant syndrome, or NMS, is driven by central dopamine antagonism. That means it presents with diffuse, severe lead pipe muscle rigidity and hyperreflexia. On the flip side, serotonin syndrome is driven by excess serotonin agonizing, which presents with neuromuscular hyperactivity. Think hyperreflexia, tremors, and spontaneous ocular or ankle clonus.
So, what does this actually mean for you? Your intervention sequence literally has to match the reflex profile to avoid a fatal error. If you see hyperreflexia, you're treating serotonin syndrome and might add oral cyproheptadine. But if you see that lead pipe rigidity and a massive CK elevation, you are dealing with critical NMS. That requires immediate ICU transfer and administration of IV dantrolene or bromocriptine. And hey, here's a really dumb but unfortunately common mistake. Never, ever intubate an NMS patient using succinylcholine. In those rigid muscle beds, it compounds intracellular calcium release and can literally precipitate fatal hyperkalemia. You gotta use non-depolarizing paralytics instead.
Module 3. Functional Impairment Thresholds, Mood, Disturbance, Overdrive.
This is where we draw the unshakable line in elevated mood presentations. The diagnostic boundary between bipolar 1 and bipolar 2 isn't just about subjectively judging how elevated the patient's mood is. It is an absolute, objective measure of functional collapse and stabilization requirements.
Here is how these criteria stack up. Bipolar I requires a manic episode lasting at least 7 days, but watch for the override switch. Any duration qualifies as bipolar I if the patient is hospitalized to prevent harm or if psychosis is present. Bipolar II requires a hypomanic episode of at least 4 days paired with major depression, but it never, ever features hospitalization, psychosis, or total functional collapse during that elevated phase. Let's be crystal clear. If a patient with elevated mood requires a hospital bed, or if they're experiencing delusions or hallucinations, bipolar II is mathematically impossible. The presence of either of these variables instantly, automatically forces the diagnosis over to bipolar I. Module 4. the mandatory validation drill.
All right, it's time to run a hyper-condensed audit of your clinical vigilance. Are you the clinical lawyer or the judge? Here is your docket. Vignette A. A 23-year-old male with 4 months of progressive social withdrawal and fixed delusions that the television is communicating with him. This started suddenly after his final university semester began. Vignette B. A 38-year-old bipolar patient in the ICU with a temp of 104.1 Fahrenheit, extreme uniform muscle resistance, and 1+ deep tendon reflexes bilaterally. Read the signals, ignore the noise of that stressful university semester, and lock in your structural differentials.
Let's look closely at Vignette B. The patient has extreme uniform resistance, which is our lead pipe rigidity, and 1+ deep tendon reflexes, which translates to hyporeflexia. This reflex physics perfectly confirms neuroleptic malignant syndrome. The single next step to reverse this pathology is to immediately prepare bromocriptine, or IV dentraline.
Finally, Module 5, the executional pearl, discerning focal versus systemic rigidity.
This is the single most frequent execution gap regarding antipsychotic monitoring. Imagine a 27-year-old man on haloperidol suddenly develops a rigid neck, moaning, with his eyes rotated superiorly and locked. When you see rigidity in a patient on a high-potency antipsychotic like haloperidol, your instinct might scream NMS. But stop and look at the objective data. His temperature is 37.1 degrees Celsius. It's completely normal.
This is the vital distinction between acute dystonia and an emerging NMS presentation. Acute dystonia presents as a localized, painful muscle spasm, like torticollis or an oculogyric crisis, typically within hours of drug administration. Crucially, it completely lacks the systemic hyperthermia, autonomic instability, and massive CK elevations that we see in NMS.
Because we're talking about an imbalance in the dopaminergic cholinergic pathways of the basal ganglia and not full systemic toxicity, your execution must be incredibly targeted. Do not needlessly stop all therapy or urgently transfer this patient to the ICU. Instead, restore the balance instantly with an intravenous anticholinergic like benztropine or diphenhydramine.
This isolating clinical finding, the presence of a focal muscle spasm combined with a strictly normal temperature, is your absolute confirmation of acute dystonia. Catching this prevents a massive, expensive, and totally unnecessary clinical overreaction.
And that concludes our docket for today. So the question now is, are you ready to step onto the floor and audit your patients as the judge? To look past the noisy distractions and rely on the uncompromised math of timelines, functional thresholds, and reflex physics? I highly invite you to review this explainer again to truly master these core execution traps. The next time you face a diagnostic dilemma, remember our rule: demand the proof, trust the physics, and make the ruling.